So I would like to invite the first speaker, Dr. Kej Wang from Australia. Dr. Kej Wang, he's the vascular surgeon from Westmead Hospital, Australia. Today, he's going to talk about the considerations for treating a short neck with endo anchors. Dr. Wang, please.
Thanks very much for the invite. It's really good to be here. It's an honor to present in front of everyone. So my name's Kej. I work in Sydney, Australia. So I'm talking about hostile necks and treatment with endo anchors in these very challenging aneurysms. And this is one that I recently had to deal with, and it showcases some of the things I'll talk about in the presentation today. So we all know what a hostile neck consists of: short, conical neck, angulated necks, and some necks which have thrombus or circumferential calcification. And I think there's a role of endo anchors in treating at least 3 of these aspects of hostile necks. So as you probably know, the instructions for use for an endo anchor is up to neck lengths of 4 to 10 millimeters. So in Australia, some surgeons have 0 experience of endo anchors, whereas other surgeons use it a lot. So I'm not sure in Asia what the experience is, but I want to talk about some of the basic things about endo anchors. And I think understanding the very basics of endo anchors will help to determine how successful we are in treating complex cases. So this is a picture that was in the last presentation. I think we both took it from Google. This is the Medtronic device. There's an outer sheath, which is the number 1. It's steerable. And inside the outer sheath, you put in the device applier, number 2. And it comes in a cassette of 10 endo anchors. Each endo anchor looks like that. So it's important to note that the length of the endo anchor is in total 4.5 millimeters. However, the part of the endo anchor that penetrates the graft material and the aortic wall is only 3.5. The remainder 1 millimeter does not penetrate. And that's important to know how far you can push the endo anchor when you have a leak. So this is more of a historical slide. In the past, the recommendation is for smaller aortic diameters, you only need 4 endo anchors. And for larger necks, which are 29 millimeters or more, you use 6. And in general, in the Australian practice, we tend to use 6 endo anchors. And this is backed up by a lot of data from bench testing. So the anchor registry, which has been mentioned today, has shown that on bench testing, if you use 4 endo anchors, it takes 49 newtons to displace the graft from the cadaver aortic wall. And it's a much higher force if you use 6 anchors. And as a comparison, a hand-sewn anastomosis, which is what we're trying to replicate with endo anchors, is between 40 and 150 newtons. So it comes pretty close using endo anchors. Another study has shown that if you space it circumferentially, like in this one up there, it has a much improved durability as well. So you can put it in a number of configurations, but the best is even circumferential spacing. So what are the technical aspects when using endo anchors? So the picture on the left, we have an aortic graft, aortic wall. You have the sheath, which the endo anchor comes in. And inside the sheath, we're pushing out the applier, which then applies the endo anchor. So to start off with, the first picture on the right, you can see the sheath is steerable. And if you have it anterior, it has a C shape, posterior, it's a reverse C. And what you want to be is you want to be perpendicular so that that C turns into a straight line. And that's very important because if that C is in a straight line and you deploy the anchor, then if you're deploying an AP, you're putting it in this position. So in my experience, some surgeons don't necessarily go to these angles. And in fact, if you don't go to these angles, you'll end up deploying anchors non-circumferentially and not equally spaced. Another important aspect is that first you have to get your sheath at 90 degrees. But even when the sheath is at 90 degrees, when you push the applier out, it not necessarily hits the lateral edge of the wall. It can hit a stent strut and then it deflects off. If you're too angulated, it might deflect off as well. So I think it's really important that you have to get it at 90 degrees. And it's important also to have a very experienced assistant. So normally when I deploy endo anchors, the primary surgeon is the one manipulating the sheath. And when the sheath is in the position, your assistant is the one putting forward pressure on the applier so that it's at right angles to the wall. And sometimes when you put the correct pressure, you might even see the edge of the wall move out with the endo anchor applier as well. And when that's the case, you can then deploy the endo anchor in the correct, accurate position. So some of the challenges in hostile necks, if the neck is angulated, I think that can present a challenge, but often the sheath is quite steerable. And I found that despite having an angulation of the neck, you can usually maneuver the sheath into the correct position and deploy endo anchors accurately. But I would say that if it's really severely angulated, it's hard to get too many endo anchors in. So in that case, maybe doing 4 endo anchors rather than 6 is more worthwhile. Secondly, if there's too much thrombus or calcification, it's really important to plan pre-operatively by looking at the CT imaging, what the level of calcification is and whereabouts. So there's a concept of using levels and quadrants to avoid putting endo anchors in those calcified or thrombotic areas. There is a fail-safe mechanism. If the screw screws out and hits some calcium, it will unscrew and you can just readjust the sheath and put it in a different position. So endo anchors can also be used to treat endo leaks. So as we heard, you can use it prophylactically to improve the neck seal, or you can come back and treat leaks. So as I mentioned previously, the endo anchor length is 3.5 millimeters. So if you have a small leak, so like in the picture on the left, it's quite small. Generally, the recommendation is 2 millimeters. If it's less than 2 millimeters and you put an endo anchor in, you're likely to get a seal. But in the picture on the right, if it's slightly greater than 2 millimeters, you might actually have the opposite effect if you try and put an endo anchor. So this is a picture, I think of it, endo anchors as applying a screw to 2 pieces of wood. So one piece of wood is the aortic graft, the other piece is the wall of the aorta. If they're already very close and you put the screw in, you're actually pushing the layers together. You're fixing it together. But if they start off further apart, as you put the screw in, you can actually push the edge of the aortic wall away from the graft and you make the leak even worse. If you have a conical neck, there's a technique known as the zipper technique. So even if the aortic wall is further away from the aorta, you can sequentially put endo anchors one by one, reducing the space of the graft to the wall, and thereby creating a seal in some situations. So these are the technical considerations, I think, when you're deploying endo anchors. You need to be very accurate and know when to use and when not to use endo anchors. Not all cases are suitable, of course, for endo anchors. So to finish off, I'll just present a case that I showed the picture of earlier, and I think it really showcases some of these technical aspects nicely of endo anchors. Recently, we had a 90-year-old presented with ruptured aneurysm, and on presentation, he was stable, and he was quite a well patient, so we decided that we should try and fix his aneurysm. This is his scan. Angulated neck. Huge aneurysm, 12 centimeters, and actually quite tortuous iliac arteries there, you can see. Coronal. So the neck is angulated. It's not too short, but it's very angulated. So this is a picture showing that it's very tortuous. The catheter from the right goes to the left, then goes up to the aorta. So we decided to deploy the main body from access from the left. And we deployed the main body, and unfortunately, there's a type 1A endo leak from the greater curvature. as discussed in previous cases. And in hindsight, maybe using the push-up technique in this case might have helped with the type 1A endo leak, but we didn't in this case. So he was 90 years old. It was a long procedure because it was very difficult cannulating the gate from all the tortuosity. And we thought, even though there's a type 1A endo leak, he's 90, we'll just leave it and see how he goes. Unfortunately, his follow-up CT scan a few days later still demonstrates persistent type 1A endo leak. Seems to be mostly from the right edge of the wall. These two pictures showing this is right up at the infrarenal neck, a gap there, and further down there's a larger gap. We thought, should we take this patient? He already had a bit of a chest infection after the aneurysm. If we can do any procedure to fix this, it would be endo anchors. That would be the quickest way to try and fix this leak. So here's the initial angiogram showing the endo leak on the right-hand side. So we put the endo anchors, first one right at the top edge of the wall, and put one on the other side as well. But there was a persistent endo leak after these two endo anchors. So we decided to put one a bit lower down. And I think this may have been a bit of a mistake because it was quite far from the wall at that stage. We did an angiogram. Leak is still there after these three endo anchors. At this stage, it was hard to, consider what should we do next? Should we put more? Should we leave it? We decided to put one more endo anchor on that side. And this is the angiogram showing with the resolution of the endo leak. We fixed the endo leak. But then we got greedy. We thought, we put one, that's in the right spot. Let's put one more because we never want to come back and treat this patient again. So we put one more. And this is the angiogram after putting that one. And endo leak is back. So very disappointing. And I think thinking back, this is most likely what happened. That one more screw, we put it in an incorrect position and we pushed the graft further away again. We've recreated his problem. So at this stage, went back to the CT. And I think on our initial, this is right at the top, right near the infrarenal neck. We had put endo anchors there and there. So we've sealed the leak there, sealed the leak there. The picture here doesn't demonstrate it that well, but there seemed to be a bit of a gap there, right at the top. So then we re-angulated to an LAO position, left oblique, and put it in that antero on the right-hand side, right there, one more endo anchor. We've already used several endo anchors here. We didn't want to put any more. This is our last attempt. If it works, it works. If it doesn't work, stop. And we were lucky to fix the endo leak in the end. So I think that in summary, endo anchors, they have a role in treating hostile necks. And the keys to success, you need to really plan carefully before putting endo anchors in and recognizing how to accurately deploy the endo anchor in the position you want it to be in is really important. Thank you.
Thank you very much, Dr. Wang, for your very nice presentation. I have one question in terms of how many rows you perform the endo anchor. 1 rows or 2 rows or 3 rows in general, in terms of the short neck or angulated neck?
I think if we're talking prophylactic use, so not treating endo leaks.
Yes, in both the first, prophylaxis or treatment 1A endo leak. Yeah.
I think it's different when it comes to prophylaxis and treatment of 1A endo leak. When it comes to prophylaxis, my preference would be to put 1 row right at the top, 6 endo anchors. But for a type 1A endo leak, like the one demonstrated, it would really depend on the CT scan, and I would try and concentrate the endo anchors in the region of the leak. So for most cases of angulated, if you have leak at the greater curvature, I would put more on that side.
Thank you. Any more question, Dr. Witawat? What is it?
For the question, I have question for the conical neck. How do you sizing or choose the size of the endograft? Because of we need the fixation and the sealing and in the conical shape, it's difficult to choose the right one.
I think it's a trade-off. If you go too large, the top of the stent might bunch up and the endoanchors may be hard to push through because the top of the stent is crimped. But if it's too small, then you haven't got seal at the bottom. So probably somewhere in between the top and the bottom if you're using endoanchors. So not too large, not too small in that case.
Any more question from the floor? Yeah. I have one more question. I totally agree with you that endoanchor should avoid in the post-aortic neck dilatation after EVA or severe calcification or the neck thrombus. I used to do the research about the aortic neck thrombus 10 years ago in the Netherlands, compare pre-operative and post-operative post-EVA in the aortic neck thrombus. We found that after perform the EVA, the neck expand, compress the thrombus almost 100%. So I think that in aortic neck thrombus, in endoanchor might use in this case is not contraindication. What is your opinion in terms of the aortic neck thrombus with endoanchor?
I think it's difficult to know for sure because you risk, if the thrombus is too thick, you can't completely rely on pushing the thrombus away. You don't know 100% if you're going to push it or not. And if it's too thick and you accept it and you put the endoanchor, it may just screw into the thrombus and not into the wall of the aorta. And then you won't fix the aorta in that case.
So in your presentation, how thick of the thrombus? More than 2 or 2.5 or 3
2 millimeters.
2 millimeters. Thank you. Okay, thank you very much, Dr. Wang, for your presentation.